All right. Welcome, everybody. I hope everyone is having a great day. I want to thank you for joining NAVREF for today's discussion on the future of lung cancer screening for veterans. My name is Rashi Romanoff. I am the CEO of the National Association for Veterans Research and Education Foundations, also known as NAVREF. NAVREF represents the network of VA-affiliated nonprofits who are responsible for facilitating and executing VA's extramural research program. We have a really exciting session today coming up focused on one of the biggest challenges facing our nation's veteran community, lung cancer. Lung cancer remains one of the leading causes of cancer-related death in the United States, and unfortunately, veterans face an even greater burden due to higher rates of smoking, chronic lung disease, and service-related environmental exposures. While the VA has made significant advances in expanding lung cancer screening and treatment, too many veterans are still diagnosed after the disease progresses at advanced stages, when treatment options are more limited and outcomes can be challenging. The VA has built one of the nation's largest integrated healthcare systems, creating a unique opportunity to rethink how we deliver lung cancer screening at scale, especially for a population with some of the highest risk factors of this disease. So, the opportunity before us is not just to find more lung cancer, but is to find them earlier when we have the greatest chance of saving lives. Earlier diagnosis can mean more curative treatment options, fewer invasive procedures, and a better quality of life for our nation's veterans. Today's webinar is going to dive in and explore emerging technologies that have the potential to change the trajectory of lung cancer among this community. We'll discuss innovative approaches that build upon VA's existing low-dose CT screening program, including mobile screening, advanced functional lung imaging, and AI-enabled non-invasive diagnostics to help detect lung cancer earlier, reduce unnecessary invasive procedures, improve access for veterans, and eventually streamline care across the VA healthcare system. We're fortunate to be joined by experts who are helping to advance these innovations, and we're excited to explore how these technologies can improve outcomes for veterans while making lung cancer more efficient and affordable for all Americans. First up, I'm very pleased to invite Dr. Amy Rose from Philips to talk a bit more about how Philips is leveraging mobile CT imaging to advance lung cancer screening for veterans. Dr. Rose, I'm wondering if before you dive in, if you want to give the audience a brief introduction as well, that would be great.
Fantastic. Hi, my name is Dr. Amy Ross. I am a pulmonary critical care doc as well as a veteran. So veteran care and the issues that follow them through their lifetime are really special to me and something that I strive to eradicate as much as possible and find ways to eradicate it across the globe in all populations.
Excellent. You want to dive in?
Absolutely. So without wait, just introducing myself again, I'm Amy Ross. I'm a pulmonologist, critical care doc, and a veteran. I want to talk to you today about something near and dear to my heart, and that's lung cancer and shortness of breath and that overlap in the veteran population. Veterans are a really tough bunch, and when we are serving, we believe we are unstoppable. And I think we are. But while we may base our identity a lot throughout our lives on the service that we performed, it is not all we are, who we will become. It's only a chapter in our lives. And we move on to the next one. But not all veterans are that lucky that the impact of their service is still telling a story in their bodies long after they've completed their service. Two of these stories veterans' bodies can tell are lung cancer and breathing difficulties, and these go hand in hand. Historically, not only do veterans have a higher rate of smoking, but they also have an increased risk for chronic lung disease and inhalational exposures to toxic agents. Veterans have a 25 to 76% higher risk of lung cancer than the general population, as well as a lower survival rate due largely to the stage of the cancer when it's diagnosed. Across the VA, 67% of lung cancers are diagnosed at stage 3 or 4. substantially higher than late-stage presentation rates for any other screen-detected malignancy, such as colorectal cancer. Advanced stage diagnosis limits your curative options, and it also increases the mortality, morbidity, as well as higher utilization of invasive procedures and greater strain on oncology and pulmonary services. Further, they are an increased risk for COPD, interstitial lung disease, and coronary artery disease. And if you look at the younger veteran population, there's an increased prevalence of shortness of breath and dyspnea on exertion. In the post-9/11 veteran population, up to 8.3% have reported clinically significant shortness of breath. These veterans sit at an intersection of the lung cancer screening and symptom evaluation, and we'll talk about why this is important. It is that intersection between screening and symptom workup where the symptoms can take the driver's seat and where a whole lung CT scan strategy can improve the speed to actionable clinical data and improve clinical coordination. So what do I mean when I say they sit at that intersection of screening and clinical workup? The VA lung cancer screening tool is for asymptomatic patients. It is predominantly based on, if you can go back a slide, please. Perfect, thank you. It is predominantly based on age and smoking history and aims for those patients between 50 and 80 years of age with at least 20 years of smoking history and have been smoking, either are smoking or have been quit within the last 15 years. That goal is a decision-making process that is shared that includes smoking cessation counseling, lung RAS reporting, registries, and program support coordination. However, veterans being at increased risk for shortness of breath, as well as other concomitant lung diseases, can present with symptoms or possibly other lung diseases. Now they are no longer in the screening pathway, but the diagnostic pathway. Now it involves more appointments with studies of the heart and lung, as well as radiographic evaluation and when necessary, specialty workup. But what happens is that lung cancer screening falls off to the side and they're no longer a part of that registry or the follow-on. Next slide. Perfect. Stay right there. While lung cancer screening is a strong push from VA, annual screening only counts if the veteran can actually get to it. Unfortunately, it is not universally available within the VA, and still many are being sent out into the community. There are an estimated 86,893 veterans that live in areas where they do not have lung cancer screening. Further, there is a 30-fold variability from VISN to VISN in screening rates. What makes this concerning is that only 35.1% of veterans diagnosed with lung cancer have undergone screening at all. And this highlights that gap in risk identification, patient engagement, and longitudinal follow-up. Next slide, please. Now, before it is taken to mean that I think the system is faulty, it is not. It is an evidence-based and well done. It just has obstacles. And these obstacles are at two intersections, and those are where screening meets symptoms and where care and screening goes out into the community. Next slide, please. Just like in real estate, location, location, location. As we discussed before, screening access varies dramatically across VA regions and states, with some areas having no VA lung cancer screening sites despite substantial number of eligible veterans. Further, rural veterans were less likely to complete annual repeat screening than non-rural veterans. What is the operational impact of this? It means that distance leads to decreased likelihood of screening, adherence to screening, follow-up of that screening, and those patients are more likely to have incomplete evaluations. So what can we do? Well, one of the things that we can look at is mobile CT scanners. And those mobile CT scanners can add some very care to those areas that do not have access to CT scanners. And the way I like to look at it is we take what's there and then we augment those assets, right? Because what they've done, they've worked very hard for in those areas. We don't ever want to say that they're not doing the best they can, but sometimes we all need a little bit of help. And how can we do that? We can do that with mobile imaging and virtual or cloud-based resources that increase veterans' access to care in multiple ways. First, the obvious is we bring the imaging to the veteran, not the veteran to the imaging. Second, with virtual imaging platforms, an example being Philips Radiology Command Center, you can augment the VA's ability to have these studies read and interpreted within the system. This means they don't go out into the community. The care doesn't get fragmented. Everything stays within the VA doors. Third, if needed for further evaluation of symptoms and or disease processes, a clinical application or overlay to those films can be done, which may allow for a more robust evaluation of both patients being screened as well as those requiring diagnostic workup. Next slide, please. In conclusion, veterans carry a high burden of lung cancer and dyspnea-related pulmonary disease. This means those patients fall at that intersection with the lung cancer screening that can make it possible that the screening for lung cancer could fall to the side as we're working up their diseases. But with a whole lung approach, as well as a mobile approach and a virtual and cloud-based technology approach, we can make a difference, which may also lead to diagnoses that have not been found that may lead to better cares for these patients. Thank you.
Thank you so much, Dr. Ross. That was fascinating. And I want to ask any attendees, if you have questions as we go, we're going to do all the questions at the end, but if you look at the bottom of your screen, you should see something that says Q&A. You click on that. I see we already got a question, so feel free to use that, and then we'll hold and sort of go through the presentations and then do the questions towards the end. So next up on our panel of experts, I'm thrilled to introduce Dr. Michael Nicholson with Robert Wood Johnson Barnabas Health Medical Group. Dr. Nicholson is going to talk a bit about how non-invasive testing allows veterans to engage in a home-based approach to early detection. Dr. Nicholson, over to you. And if you want to just say like next slide as we go, I think that will help the folks kind of help drive from behind the scenes.
Sure, absolutely. So I'm Michael Nicholson. Thanks, Rashi, for the introduction. Pulmonary and critical care doctor, trained at Temple Lung Center, specialized in advanced lung disease and lung transplant, and at a high-volume pulmonary practice, university-affiliated in New Jersey, with a lot of oncology and thoracic surgery connection, a lot of exposures in our area, smoking, veterans as well, so a lot of high-risk patients and high-risk nodules. And when we're talking about this topic, the number one step is exactly what Dr. Ross touched on, which is getting those surveillance numbers up. All of the people who meet the criteria, that is our goal, to get them their CT surveillance. When you do that, you do have an influx of nodules, and you need to know, what do we do with these nodules then? And that's kind of where CyPath comes in. It's a non-invasive test to help you detect which patients and which nodules are more worrisome and require more workup. So next slide. That's my disclosure statement. And next slide. So CyPath serves an unmet need currently in the pulmonary field. Nodules are becoming more prevalent. Lung cancer surveillance programs are becoming more robust. We're finding incidental CT findings from ER visits. Coronary artery calcium screening are revealing nodules. And clinical guidelines are really lacking in what the next steps are when we find a nodule. There's basically repeat CT, get a PET scan, or biopsy it. The question is not finding the nodules. The question is, what do we do when we find them? Next slide. And what we want to do is we want to increase our pretest probability. Every decision we make in medicine is deciding on our pretest probability of what the best next step is. What is the probability this is cancer in order to go for a biopsy or a surgery? And so a patient that a lot of pulmonologists would be familiar with, a gentleman who's high risk, had a low dose CT, has a 6 millimeter left lower lobe lesion. He has emphysema, high risk for a pneumothorax from a transthoracic needle biopsy, difficult location for a robot, and a patient who's 8 years old and may not want to do more workup unless you can prove it's worth his time. Next slide. And so when we're risk stratifying this patient, currently our tools are lacking, and they give us a lot of different information. So there's multiple calculators you can use. There's the Mayo Clinic Solitary Pulmonary Nodule Calculator, Brock University Bayesian Inference Calculator. And when you look at just for this patient, all of these different numbers, anywhere ranging from 1% to 12.5% chance of malignancy, all recommending different next steps for the nodule. And when you're committing someone to a biopsy, it's a big decision. So you go to the next slide. So for example, what are our typical next steps? A PET CT is not going to be sensitive or specific for a 6 millimeter nodule. A robot-assisted bronchoscopy is going to have a 60 to 70% yield, which may be less in a 6 millimeter nodule. That data is from nodules altogether, with a 3% pneumothorax rate. And a CT-guided biopsy is going to have a 60 to 90% yield, probably at the lower end of that based on the size of this patient, and almost a 30% pneumothorax rate, which is probably on the higher end for this patient with his emphysema. So before committing to them to this procedure, which takes up healthcare resources and may expose them to unnecessary risk, CyPath serves a role in helping to risk stratify this nodule. Next slide. It's going to give us another data point. It's independent of imaging. It's not replacing our imaging. It's saying we have our imaging. Let's get some more information to base our next decision on. Next slide. And so the way that CyPath Lung works is it's a sputum test, and it's not actually looking for cancer in the sputum. What it's looking for is it's looking for changes in the lung chemistry and microbiome that reflect that cancer may be in the vicinity. It's run through flow cytometry and powered by an AI, which has been trained to detect changes in epithelial cells of the lungs associated with lung cancer being in the vicinity. Next slide. What's really wonderful about CyPath Lung, as physicians, sometimes it's difficult to get our patients the tests and the care that they need. When it comes to CyPath Lung, in my office, I fill out the requisition form, I send it to CyPath, and they take care of the rest on their end. They assign each patient a patient coach. They mail them the kit for collecting sputum, and they talk them through how to do it over the course of 3 days. And then they collect the package from the patient and bring it back to their own lab. So it's one of the few things in medicine that you can just kind of sign the form, know that you're getting good data, and it's being taken care of. It doesn't require much effort on the side of the patient, which is something that they like as well. As you can see, the numbers there we'll talk more about. High sensitivity, high specificity, and specifically very high negative predictive value. Next slide. And this is kind of our flow as we see a patient in the clinic. If they have a chest CT, it gets sent to their home, the CyPath kit, it goes to the lab, and then you as the physician who ordered it gets a report. Next slide. And these are some of the parameters that we mentioned. We won't go into a lot of detail about that. But when the sputum goes through the flow cytometry, it's looking for different things such as the amount of apoptosis occurring, porphyrin uptake, which is associated with cancer cells, and making sure that cells like debris and mucus are washed away, and we're only studying viable lung epithelial cells. Next slide. When you send the CyPath, after you get the report back, it will give you a reference range, and it will show you where your patient is on that reference range based on the AI algorithm, and tell you what the likelihood of the malignancy is. If you're to the left of the 0.5, it's unlikely to be a malignancy. If you're to the right of the 0.5, then it's likely a malignancy. Next slide. So if we go back to our patient James in our case study here, he had a CyPath lung done, which showed unlikely to be lung cancer. He had serial CT scans instead of a robotic biopsy, and on follow-up CT scans, there was no nodule. So in this case, CyPath served exactly the role that I've seen in my practice. It served many times, and that can be helpful when we're getting so many nodules on our low-dose CTs, preventing an unnecessary procedure. Next slide. What's great about CyPath Lung is that in the studies, it's been shown to be consistent across nodule sizes. The best numbers are in those nodules between 6 and 20 millimeters, but there is no size cutoff for the nodules. That's important because that 6, especially 6 to 1.2 centimeters, you see the sensitivity of 100%, specificity near 90%. Those are the nodules that PET CT may not be sensitive or specific enough to pick up. So when you're not able to rely on PET CT, CyPath is a great adjunctive test to give you some more highly respectable data on the nodule. Next slide. It's also shown to be consistent across types of tumors and stages. Our goal is to catch them all at stage 1. Unfortunately, that doesn't happen, but CyPath still performs equally as well regardless of the stage. Next slide. When you compare CyPath lung to a PET-CT itself, you can see that the sensitivity, specificity are close with the specificity better in CyPath lung, and the negative predictive value being very powerful in CyPath lung, almost 95% if we're assuming a lung cancer prevalence of 10%. And that's what was assumed in the PET-CT studies as well. So you don't have the same restrictions in terms of the nodule size as you do in a PET scan, and you're not sending the patient for an image that they have to schedule, may not show up to, and wait months to have done. It's a test that can be collected from them in a week and sent back to them with your results to give you some really good data on what the next step should be. Next slide. This is just some data comparing it to other diagnostics tests and other organ systems, things you'll be familiar with. So the FIT test, which is like our Cologuard test, mammogram, obviously, and then a PSA with our normal cutoff there that's usually used for PSA. And it's showing that in most cases, specificity, sensitivity, negative predictive value, positive predictive value, they all line up pretty equally with these other highly utilized tests in other organ systems, cancers-related screenings and surveillance and of that nature, and performing better in some cases. Next slide. An important part of this is the savings to the healthcare system. So this was actually a study done by a VA medical center, and it showed that incorporating CyPath lung into a lung surveillance program following low-dose CT scans could save significant amount of money to the healthcare system, about $370 million for Medicare patients and almost $900 million for commercially insured patients. So covering both the clinical, patient, and financial aspect. Next slide. When you compare it to other tests available for lung cancer, non-invasive tests, Notify Lung is one of the main ones. That's a serum test. And it does have a lot of limitations, including it's limited to use in nodules 8 millimeter or larger. Patients may have specific risks that they can't use. There's a cancer diagnosis within 5 years. It excludes it, but none of these apply to CyPath. You can use it on any nodule size. The patients can have had other cancers in the past. They can have a type of risk factor for lung cancer, and it's never going to give you a we're not sure indefinite result. It's always going to tell you, as long as the patient produced an adequate sample, is this unlikely or likely to be malignancy. Next slide. This is a practice algorithm that a lot of the pulmonologists who have been using CyPath in our area have begun to adapt, and kind of where it can fit in very well for your nodule program. And you can see in the corner there, we talk about the negative predictive value of nodules less than 20 millimeters is 99%. Positive predictive value is 61%. So whenever you are finding these nodules on a low-dose CT and a CyPath lung is ordered, it's helpful both in the setting of nodules that PET-CT is not working up or nodules that PET-CT is working up. What it really does is gives you another data point to help make our next decision better and supported by more evidence. It serves many purposes. It helps the patients to have peace of mind when there is a negative result. If they're waiting 6 months for another scan, this is not on their mind for the next 6 months. I wonder if that nodule's growing. I wonder if that nodule's growing. It's more of, okay, this said it's unlikely to be malignancy. It's 99% accurate, so I feel good about this. On the other end of it, the more nodules we get, we can find as many nodules as we'd like, but we are limited in our capabilities of biopsying and intervening on these nodules. We need to reserve biopsies for patients who are high risk, for patients who need them, who have a higher risk for malignancy. So CyPath helps you to stratify which patients need a biopsy or a surgery more acutely, and utilize that resource of interventional pulmonology and thoracic surgery better than just biopsying any type of nodule that shows up, not exposing our patients to excess procedures, adverse effects, and allowing us to make the right decisions for next steps for them. Next slide. So in summary, it's a non-invasive test. The patient produced sputum over 3 days. That's the extent of what they have to do for the test. It has a very high negative predictive value depending on what nodule size you're using, but overall, 96%. It's especially useful in those nodules that are less than 20 millimeters. It gives you crucial diagnostic information to help you decide the next step, understanding what your patient's probability of having lung cancer with their nodule is. It provides them with a lot of peace of mind, and it informs your shared decision making. There is a lot of resistance to pursuing procedures, but if you have a positive CyPath lung, sometimes patients are more willing. Even though you tell them, hey, this is not 100% accurate, as a 61% positive predictive value. But the fact that it's positive moves you, in my mind, into a higher risk category that we should intervene instead of just watching and waiting. And the final step is that it makes the lung cancer screening programs more efficient and more cost effective, allowing us to serve more patients better from a clinical and financial perspective. Next slide. Thank you. I hope that was informative for everybody. Looking forward to taking some questions.
Thanks so much, Dr. Nicholson. That was great. And a reminder for folks, if you have questions, feel free to just submit them using the Q&A function at the bottom there. Our final panel of experts, we're going to turn things over to Dr. Greg Mobile with 4D Medical. Greg is going to be talking about the latest in advanced imaging for lung cancer screening. So, Greg, over to you.
Hi. Hope you can hear me well. Thank you so much, Navrat, for inviting me to speak. And it's an honor to follow the presentations that I just heard. I am Greg Mogul. I am a practicing radiologist. I am a former Army major, trained at Brooke Army Medical Center, and have been involved in active duty and veterans care my entire career. So, to everyone on the phone, and Amy, thank you for your service, of course, which is continuing. My passion around population health and the use of imaging in reducing human suffering is the thread of my career, and I'm lucky to be the Chief Medical Officer of 4D Medical. Next slide, please. Where we've gone from the possibility of expanding access to advanced diagnostic images specific to the lung, the heart and the lung, but I'm going to really focus on lung today. In this age of AI and AI companies and imaging, there's a lot of noise, a lot of excitement. I just want to establish that as a company, we've been doing this a long time. We are utterly committed to pulmonary health. We will not have a stroke algorithm next week or an ankle fracture algorithm next month. Everything we make and everything we do is based on extending people's health in cardiopulmonary sense. So we've been at this quite a long time. Everything I'm going to be presenting to you today are FDA cleared, commercially available techniques and technologies. As a former military physician, very sensitive to the idea that we are not suggesting experimenting on our service members or our veterans. These are tools that are currently available in the real world. Next slide. Have some really basic core mission principles here, which is that we need to meet the veteran where they are, the service member or the veteran, that where you find yourself with an illness should not represent anything to do with your course of care or your outcomes. Secondly, that with veterans, we need to provide care that's based on their service. We have information about veterans. We are lucky to have shared information systems and to enter into the care of veterans with knowledge about where they've been deployed, what work they've done, and everything that Amy described very clearly about some of the lifestyle issues that impact veterans and the fact that they are widely spread geographically throughout the country. It's important for every physician to realize that you are providing veteran care, not just physicians in the VA. Many of your patients are veterans. You may not even know if you're a radiologist or if you're a pulmonologist or whatever your specialty is. Every physician in this country is providing care to the people that have served. And I think we all need to be more mindful about that. Given the previous two facts, especially the fact that many veterans live in traditionally underserved areas, we have to maximize every visit. Every time we get hold of a veteran who's come in for any care, screening, treatment. We want to make sure to do everything possible to provide them as much service as we can, to extract as much information as we can that might support them later without providing unnecessary tests or unnecessary radiation exposure, obviously. But our principles at 4D Medical are based on these issues. We produce software that takes existing imaging that's delivered in most cases by a CT scan, by the CT scans that Dr. Rose showed inside those trucks, and we leave nothing unturned. We take every piece of information that is on that scan, from the veteran's lung function to its structure to the presence of nodules to future information that may be useful should that veteran have other historical facts in their record, such as having been exposed to having toxic exposures during deployment. So we want to make sure that when we take that scan, we leave nothing behind on that scan, that we bring it all forward. Next slide, please. So we've been talking about lung cancer screening here. I'm a passionate supporter of lung cancer screening. I actively read lung cancer screening to this day and have been involved in it since the NLST in 2014. As a country, we have about a 15 to 20% acceptance of lung cancer screening. That means 80 to 85% of patients who could get, who are eligible for, who have it indicated, and who could get a lung cancer screening scan today for no cost are not getting it. That's way too complex a question to address in this issue, and the VA proudly has done much better than that, much higher numbers in the VA, but still less than half. And no one believes that the existing recommendations for who should receive a lung cancer screening today will be the recommendations in 1 year or 5 years or 10 years. There are publications everywhere that suggest subpopulations and veterans, first responders, firefighters, these are populations who are clearly at higher risk, as Amy has pointed out. So not only should we be getting more information and getting them more available for lung cancer screening using great technologies like CyPath that Dr. Nicholson talked about, but there's a lot of information on that scan, and we can't leave any of it behind when that veteran makes their way to the scanner. Please, next slide. So when I look at a CT scan of the chest, just a low-dose, non-contrast CT scan of the chest, yes, there may be nodules, but less than 2% of patients who come in for lung cancer screening have fully actionable nodules on that screen. That's not bad. That's the way it should be. That's what screening is. But well over 10 to 30% have coronary artery disease, have signs of COPD, have other causes such as interstitial disease that may lead to breathlessness, symptoms which over 30% of veterans experience post-deployment, because there are so many causes of this. Some are pulmonary, some are not. Next slide. So we think it's absolutely critical to, along with the evaluation of nodules, which we've been discussing here, to make sure every veteran has clear, quantitative, reproducible, documented evidence of the existence of emphysema. And we have a specific technology that will do that. The existence of coronary artery disease, any underlying signs that suggest early or undiagnosed interstitial lung disease, and of course nodules. Each one of these is a tool that can be applied passively in the background and support the radiologist who's performing the reading. There's unfortunately a lot of variation among my guild radiologists in what's mentioned, what's not mentioned. These are very subjective findings that aren't always reported exactly the same way. And so having reports, next slide, please. For example, this is the analysis that comes from a coronary artery calcification score. You'll see it produces an Agatston score. This is from a low-dose, traditional, non-contrast CT of the chest, non-gated, acquired on any CT scan, perfectly acquired on the scans from Dr. Ross's mobile units. These are calculated in the cloud, and these reports are returned immediately, and the information can be included and actionable steps can be taken. I don't have time to show you every report for all of the conditions, but we had documented FDA-cleared reports for interstitial lung disease risk, for quantitative evaluation of emphysema. Next slide. Along with that, we produce, for smoking cessation, we produce personalized reports for patients that, because really, for a lot of people find lung cancer screening to be a powerful smoking cessation tool. And in many cases, this is one of the most effective ways to reach that point. Although many of these patients have quit, most of them have not quit. And providing them actionable, direct reports that can show them the impact on stopping smoking and support smoking cessation counselors in the large percentage of patients who have evidence of emphysema without a nodule. We don't want people who have significant coronary artery disease, who have significant emphysema, who happen to have come in for a lung cancer screening scan, who may be remote to a VA and not particularly interested in visiting the doctor, to go away and not realize there are other things they can do to improve their health long term. That's good for the VA. That's good for taxpayers, especially bottom line, that's good for veterans. So we're passionate about not leaving any information behind. No additional radiation exposure. Next slide, please. Almost done. But the reality is that beyond lung health screening, that same CT scan, a CT scan that can be acquired on a traditional CT scanner, a mobile CT scanner without the use of contrast, can actually be used to begin the treatment planning and even post-treatment assessment for patients who have already been diagnosed with diseases. They may have lung cancer and they may have a nodule that's identified. That is a patient who eventually is going to require a lot more testing that may require many other advanced imaging tools like nuclear medicine, ventilation and perfusion scans to determine the health of the lung, for planning surgery, for identifying lung sparing opportunities in radiation or therapy. Patients with COPD who can now be treated with devices that didn't exist 10 years ago, endobronchial valves, that they can't even begin to get assessed for without visiting an academic medical center that may be 4 hours from them. If we acquire this information from their first CT, then multidisciplinary teams that may be located at a great remove from these patients now are going to have access for the first questions that need to be asked about treatment. And ultimately, something that I simply don't have time to address today, but a huge issue is the issue of toxic exposure of veterans, burn pit exposures, the issue of what is largely called deployment-related respiratory disease, variably called deployment-related constrictive bronchiolitis. This is a massive problem for veterans and the VA. Many patients, millions, have been exposed, have signed up for PACT Act benefits. Triaging these patients, determining which ones have more traditional lung diseases like COPD, asthma, or actually have deconditioning or cardiac disease. One of the greatest constraints that the VA has is its access to pulmonologists who have the kind of information and the advanced tests to take care of patients who may actually have toxic exposure. This will not be the majority of patients with symptoms because common diseases are common. But these patients take years and years to diagnose and currently are often only diagnosed with a biopsy. And I don't mean the kind of biopsy that Dr. Nicholson was talking about. I'm talking about a surgical biopsy that has significant risks, significant impairments to the veterans. Next slide. So with these same CT scanners, we have additional technologies in the right cases where there's a history that's relevant, where there is chronic shortness of breath that has not been explained, where we can actually use these FDA-approved technologies, next slide, to, for instance, show ventilation and perfusion maps, just like a nuclear medicine VQ scan, which is a difficult, expensive study to acquire that no one likes, not even nuclear medicine doctors in many cases. On an inspiratory, expiratory, non-contrast CT scan, we can show quantitative and qualitative regional ventilation and perfusion. These are incredibly important facts to know about a patient to determine treatment options. Biomarkers are being produced that show specific patterns of ventilation and perfusion heterogeneity. We've recently published this in the Blue Journal. Heterogeneity that suggests underlying primary lung diseases or suggest someone's success in treatment. Next slide. Last slide. Well, actually, this is just another slide showing the traditional nuclear medicine scan on this patient, which was acquired weeks later, thousands of dollars, and at great personal expense to the patient. Below is a perfusion on your right, and a ventilation scan derived from the exact CT scan that the patient already had, and shows areas of decreased perfusion, decreased ventilation that match the nuclear medicine scan. Next slide. So the message here is that these veterans deserve our care. They deserve all the care they can possibly get at every single visit. They deserve the information to be centralized, acquired close to where they are, and acted upon in a centralized fashion by the best team. I think all the technologies you've seen today represent the future of pulmonary health for veterans. If we have only 20 to 30% of the patients currently being screened who should be screened, and people believe it's much more, you're going to need every one of these technologies to actually see us get to the point of 100% penetration, which would be a dream come true for our veterans, for the VA itself, for the country. Thank you.
Thank you so much. I want to thank our panel of experts. I feel like I could talk to each of you all day long about the research you did, but that was a nice sort of like teaser of each of your areas of expertise, and I think sets us up for a really great discussion. And I really want to thank Drs. Ross and Mogul additionally for your service. And I think feel free to answer the questions sort of professionally wearing those hats, or I have a couple questions. I might go off a little off script from what I sent on some other veteran perspectives on all of this work. One question we received, and Dr. Nicholson, this is for you. You know, the VA system, it's been in the news a lot, right? It's facing significant demand. And some of this, I think, Dr. Mogul, you mentioned with things like the PACT Act and having such a surge of veterans now coming into the VA. You know, we know that this surge in demand can lead to challenges getting appointments and, you know, just getting in and diagnostic procedures. How do products like CyPath really help address some of those access challenges, and what role do you see it playing as we think about improvements to the patient care journey in this environment?
Yeah, and that's a huge issue, is the access to the appropriate technologies that Dr. Mogul touched on in detail. And it's funny, an oncologist in my area said something similar to me when I first started speaking to him about it. He said, and this is not a way that it's been studied or approved, but it's a way that people are using it. The oncologist said, I see this as the Cologuard of the lungs. When I have people who don't feel like going to get a CAT scan of the chest, when I have people who aren't reliable for that, I can order this for them. I know it's going to get sent to them. Someone's going to call them. It's minimal effort on their part. And at least I have a point of information in that. And if it's positive, I have a little bit more gusto in which to convince them, hey, you really need to get that CAT scan. So CyPath is not designed in a way to replace our standard screening, but it serves as an adjunct. And each patient, the way that benefits them, an adjunct to each patient is different. So if that's then encouraging them to get a CAT scan, if that's encouraging them to get a biopsy, if that's avoiding a procedure, if that's avoiding unnecessary next steps, that's great. And it's a huge, CyPath is huge for patient access, the way that it's set up to be delivered.
Yeah. And I wanted to ask, and this is sort of a patient question, because, you know, I think what was really interesting, Dr. Nicholson and Dr. Ross, this might be more for you all, since with the mobile screening and the at-home testing, what has the patient response been, right? To, like Dr. Nicholson, you said from the provider experience, you're like, this is great. I ordered it. It sort of all happened behind the screen and then was brought back to it. I'm curious if you can speak a little bit to how patients feel about interacting with this. And Greg, maybe even something for you to loop in. You know, I loved that sort of reporting back to the patient on like the state of your lungs, if you will. So just curious how not only patients and then maybe for Greg and Amy as veterans, how are veterans feeling about these new kinds of technologies and, in many ways, sometimes being first in line for them. But Dr. Nicholson, I'll go to you first.
Sure. The patient response has been great. Initially, when I start describing it to the patients, the number one first response I get is, but I don't really make mucus. And I'm like, don't worry about it. Someone's going to call you, coach you through it. They give them tips on how to do that. And everyone who comes to the office afterwards says how easy it was. We get a quick turnaround, so a lot of times I'm calling the patients with the results before their next appointment and saying like, hey, this came back negative. It's really encouraging. I feel comfortable that we're repeating your CAT scan in 6 months. And they react to it the same way they would react to a negative biopsy or something. Oh, thank God, I'm so happy. I'm so relieved. Things like that. And on their end, they all said, yeah, I got a phone call. They sent it to me. I did it, and they came and picked it up, and you got the results a week later. They can't believe how accessible it is and how much it doesn't interfere. They don't have to take off work to do it. They don't have to drive 45 minutes to an hour to do it. They don't have to be on hold with a radiology center for an hour to make an appointment. It's all very easy accessible, and the response has been really great from patients.
I'll say one thing, people, unexplained shortness of breath, people losing their exercise capacity. This is one of the most common human complaints. I mean, headache, belly pain, and I can't breathe right. I mean, this is what we suffer from. And veterans suffer from these things at a much higher rate than the standard population. And I'm a former Army doctor, and, there is a cultural thing here where it's like, suck it up, buttercup, and the whole thing, right? And no one is more likely to suck it up than people who have served in the military. And so there's a culture of saying there's nothing wrong with me, and there's a culture of quietly sticking it out. But this problem is massive. It is a huge drag on the entire healthcare system. The simple complaint of, I can't get a deep breath, especially since COVID, drives so many people to care. And there's no organized way. If we tried to treat diabetes or if we tried to treat anything else with the lack of standardization, some patients go to a pulmonologist, some patients go to primary care, a nurse, the emergency room, some get a CT, some get PFTs. Many people have put in the chat questions about the recent announcement that members of Congress have put forward a plan to try and use some technologies to take these individuals, often who are PACT Act beneficiaries, who have shortness of breath. As I said, I believe them. We must believe them. It can't be that everyone who has this complaint somehow is gold breaking. That's just not true. These are not people who do that. But the reality is most of them don't necessarily have changes that are from their exposure, but they deserve the workup, and it doesn't matter. They want to know. And I have seen veterans driven to tragic extremes, from being driven around the healthcare system for sometimes a decade, being told there's nothing wrong with you, being told it's in your head, being told, it's just asthma and I don't know why you're not getting better. We need an approach to settling that question much earlier without everyone having to wait 2 years to see a pulmonologist. And so I think that's what that Air Care bill is about. And I think giving veterans a clean bill of health for everything from here to here is something that is in our interest. And they're happy to accept that they might have COPD or that they need to exercise more. But we need to be able to communicate that information reliably, factually, quantitatively, and respectfully. And so that's really part of the mission, I think.
Excellent. And thanks for tackling that legislation question. I was trying to debate how best to phrase it, not to put anyone on the spot on commenting on Capitol Hill these days. Dr. Ross, I want to bring you in. One of the things I really loved about your presentation was sort of this, how are we bridging the divide between screening and diagnostics? I really liked how you sort of framed that out. And, to me, programs like Mobile CT is designed to ensure that it's supporting veterans along that whole sort of screening pathway, right? So can you talk to me a little bit, and you mentioned it sort of briefly about beyond just initial scans, sort of additional diagnostics, but how is Mobile CT really designed to support that entire screening pathway and sort of the next following steps? Oh, I think you're still on mute. Sorry.
So to go back to what Dr. Mogul said about zip code should not define destiny, location should only count in real estate, right? It should not count in medical care. And we are not going to be able to get people to move from where they live because they want to live there. But we also aren't going to get those doctors to move to where there are other patients because they live where they want to live. So how do we bring this together in a world post-COVID where virtual technologies as well as mobile technologies can really play that role? And I think that mobile CT with that remote connection into the VA system, we may not have a radiologist in that region, but we do have one, let's say, somewhere else that can do those readings. So how do we create what I call that umbrella? It's raining, but we got to get everybody under that umbrella and then build a roof, right? But the first step is building that umbrella. And that umbrella comes with bringing the technology to them. You are talking about a population who will always put others first. And they will take care of their families. They will take care of their jobs. They will take care of everything before they take care of themselves. And one of the things they worry about, especially in these populations, is the hardships that they put upon their families to travel to these appointments. Well, why should they have to? Why can't we find, unique ways to solve these problems by bringing the technology to them, whether by mobile or with the bricks and mortar CTs that are there that maybe we can upload into different systems and train those techs. So I see this as a multimodal kind of approach. Mobile CT for those areas that don't have enough assets, as well as kind of that virtual and that cloud cover, right, where we can put those CTs up into that cloud to have programs like 4Ds put onto it to look at the patient, because whether you're out on the battlefield or you're at home, the areas of most concern are injuries from the neck to the hips, and specifically in that chest region, because if we can fix those early, whether on the battlefield or here, people survive. And really understanding what those look like and giving them that information where, hey, you have a nodule or you have lung function impairment, maybe you need to quit smoking, but we can get a picture that you add in Dr. Nicholson with the CyPath. Maybe they don't need a biopsy, or with the 4D medical where we can look at it and get a better idea for the shortness of breath so we don't have to do a biopsy. Things that are invasive that don't need to be done but can be done in their communities, and those doctor's appointments can be done remotely, and they can bring their families in and have that shared learning. Because what works best about that screening tool for lung cancer is the shared decision making. Dr. Nicholson touched on this multiple times, that shared decision making, where we empower patients to take control of their lives. Well, when you get into that diagnostic side of things, that shared decision making kind of goes away, and people are living in fear, and they have all that traveling. So what are those steps where we can do a whole lung? And I really like to think of it as a whole chest approach, where we're looking at the heart and we're looking at the lungs, and we're not just looking for lung cancer, but we're looking at how well do your lungs work? Is there calcification in your heart? All of those things that, we get questions about in clinic, because those patients, as Dr. Mogul has alluded to, get moved around from specialist to specialist, because you can't overlay PFTs on a CAT scan, and you can't take a 6-minute walk and really apply it to anything. 6-minute walk just tells you if they get hypoxic, right? Pulmonary function tests tell you how well they can blow out that breath. But when you've got an elite athlete who says, I used to be able to run 6 miles and now I can barely do 2, and everyone looks at them and says, but you can still do 2. Okay, but that's not where they were. So in a bit of a roundabout way, meeting patients wherever they are, both mentally, physically, and spiritually, with that shared decision making so that they feel valued, heard, and understood. And I think that starts with bringing it home.
Absolutely. And I think thinking of how all these technologies gets us closer to that is really, really exciting. So I want to ask, I think we have time for one more question, and I'll ask everyone to jump into their time machine. So, we're 5 years down the road, right? And what I want to ask, and maybe Dr. Nicholson, I'll go to you first. Where do you see the field of lung cancer sort of moving towards in the next 5 years? And how are you thinking, as a physician, how are you thinking about, how are you preparing your practice for that? How are you thinking about how your patients are going to, what that's going to look like for them? Talk a little bit about what the next 5 years means.
Sure. I think improving the people who qualify for screening and are being screened, and also expanding the people that are being screened. So if you look at the American Cancer Society, their recommendations are actually different than the USPSTF for lung cancer screening. And they don't have quit 15 years ago, 20, they have a strict, if you smoked, you should have a lung cancer screening. It's not about when you quit or anything like that, no matter how remote the history was. And when you look at the cardiology guidelines, they are recommending more coronary artery calcium scoring. So that's going to find more nodules in high-risk patients, because a lot of those patients are smokers and have other risk factors as well. So it's going to be a large influx of nodules, and that's a good thing, because the number one prognostic factor of lung cancer is the stage. My goal, and the goal of everything with lung cancer, is not to, obviously we want to prevent lung cancer, but we're never going to completely prevent it. It's to find it at an early stage, and we can see it transform into other types of cancers and other types of diseases where finding it early, surgically removing it, there's SBRT, there's new therapies like percutaneous therapies for lung cancers that you can find and treat a local lung cancer, and patients can go on with their lives and forget that it was ever there, the way that we do with diseases that used to be lethal in the past as well. So to sum that up, the idea is do more screening, find more nodules, diagnose the right patients with cancer earlier, and treat it definitively at an earlier stage to improve our survival. And that's the goal of any screening program, and lung is lagging behind a bit, but we have the people like Dr. Ross and Dr. Mogul and the resources to start to make that more of a reality.
Love those comments. One of our industry consortium members at NAVREF always talks about thinking about cancer as a rare disease, right? Like building a future where we're getting so good at screening and the therapies are all so specific that it's a rare disease, which I really like that way of thinking. Dr. Mogul, over to you.
Yeah, we live in a world where the majority of people who get lung cancer have never smoked, and that number is increasing. There's lots of thoughts about that. Certainly there are environmental stressors that didn't exist before. There are genetic causes. There is a recent rash of young Asian women who are experiencing lung cancer, never smokers. We don't know where this is coming from. I think over the next 10 years, the fastest growing single imaging test that's going to exist is going to be the low dose CT of the chest. And we have an obligation, and that's globally, and we have an obligation to treat all the diseases that may tell us about. I think Dr. Nicholson's point was absolutely spot on, that we have to have the right patients get screened, which right now they're not. Even the ones we agree should get screened are not getting screened. We as physicians and as a healthcare system need to look in the mirror and say, why are we not encouraging this? We need to identify who they are, because it's not the people getting screened now. And we need to take every single piece of information that we have and use that information to give them the best quality of life and the longest health span they can have, which on a chest CT is often going to come from information about their heart or information about their lungs that's not cancer-based with the growth of COPD and interstitial disease. So I am excited that we're going to look back and we're going to see age-based and much more rationally based chest health screening, which is really like a biopsy of a lot of systems of your body. And that's going to be a great thing.
Amazing. Dr. Ross, final word.
Yes. So I have a dream, and my dream is that we build our repository of what does it mean to be at risk. And what to me that means is that those folks who are either with those risk factors or with those exposures, that we start screening them early and doing the questionnaires, whether it's about shortness of breath or doing the scans to look for malignancy, cardiac disease, all of these things. Because if you look at a veteran population, they're at risk for COPD, interstitial lung disease, lung cancer, and cardiac disease. And all of those things can be looked at in that annual scan. And when we think about that from a perspective of how do we roll this out in general, it's not just our military, it's our first responders, it's our police officers, it's our EMS, it's people who respond to fires, people who respond to tragedies and drastic things that happen around the world. So if we can just not only look at our veteran population, but start playing that out to say, how do we make it the Cologuard of the heart and the lungs, and not just about preventing cancer, but preventing irrevocable lung disease that has significant impact on quality and quantity of life. That would be the magic point for me. Because then patients have the ability to intervene on themselves and to shared decision making that we preach about, but we don't always get to.
Excellent. I want to thank Dr. Ross, Nicholson, and Mogul for sharing their expertise today, and for the important work that each of you are doing to advance lung cancer screening for veterans. I think today's discussion made one thing clear, at least for me, and that's that the future of lung cancer screening is really going to be about bringing together these innovative technologies that are expanding access, that are improving early detection, and that are really aimed at helping clinicians make more informed decisions. And whether through mobile screening, advanced imaging, or non-invasive diagnostics, these innovations really hold the potential to ensure that more veterans are getting that right care at the right time, which so many of us talked about today. At NAVREF, we're proud to bring together VA research leaders, clinicians, nonprofits, industry partners, because innovation is really what's going to make the difference in translating all of this great work into better care for veterans. So I want to thank everyone who joined us today, and I want to thank our panelists for their amazing remarks. We hope this conversation inspires continued collaboration. And for those of you that are interested in learning more about VA research, actually the SciPath research that Dr. Nicholson presented was something that NAVREF was able to support through our network. So for anyone interested in learning more about VA research, please don't hesitate to reach out to us at NAVREF. Thank you so much, and have a great rest of your day.
Thank you.